I actually participated in the Radius chin and jawline overall study that really focused more at the jawline. It was needle, it was cannula. I'm presenting some of the data coming up very soon, and I'm overall impressed at the ability of these pictures to really show how good people can look with just injectable balance, not touching the cheek, but just restoring definition and contour to the jawline itself. When you're advising patients on really overall duration, Michael, for instance, when you're having this conversation where people can talk about, having surgery versus an injectable option, how does this sort of formulate into the overall plan? When we do things off label, we're really citing durability based on usually the nasolabial fold and a 2-grade improvement. And that's really hard to explain to a patient that this is a different area and that this is not as dynamic an area. And really the duration may be significantly longer, not surgical duration, but significantly longer than it is in the nasolabial fold.
Yeah, anytime I'm discussing augmenting, the jawline or the chin with a dermal filler, I always preface it by saying, yes, this is something that's temporary. I never quote the studies that say 12-month duration, 18-month duration, because we all know that 100% of the filler isn't there at 12 months, and we don't really know how much is there at 12 months. So it creates such a deceptive expectation. So I'll frequently say there's a range of around 6 to 9 months that most of the filler will be present. You're probably going to repeat it in somewhere in that timeline. Everyone's different. Everyone breaks it down, sometimes more rapidly, depending on what area it's injected in. And so I really create the expectation that if they're going to choose to do dermal fillers, at least the ones that are hyaluronic acid based, they're going to have to come in to touch it up to maintain it over time. Now, for some of the patients that I'm comfortable with, that I'm comfortable with their aesthetic, they're comfortable with me, and I've already done some HAs on them, I will recommend some longer acting fillers. I'm a user of Belafil. It is by no means the #1 filler that I do in my practice, but I certainly do utilize it for people that are looking for something that's a longer lasting, short of surgery.
And we know from some recent evidence that people who do these high metabolic activity type of sports do lose volume differently than other people. So the temples and the cheeks are those areas. So, we see people who train for Ironman and Ironwoman type overall races that may actually have a lot of volume loss in the cheeks. Corey, I'm sure you take care of some of these patients. I know you're a weightlifter and an exerciser yourself. So talk to us really about your approach to these patients in terms of gradual restoration of these areas versus somebody who, may have an event coming up and they really want to look overall like they have more volume in the cheeks.
Sure. So I've mentioned before the fact that we really try to stress the importance of relationships. And one of my favorite things to do is to track a patient from, 5, 6 years ago when we first started to work together and look at their development and their progress to this point, because that really does tell the story of small tweaks and small additions here and there can really keep them looking like themselves, keep them true to their own aesthetic, comfortable in their own skin, and just gives them a better overall picture. It also, like Michael was saying, it's great to be able to use a mix of different products to achieve different goals. And I know that the HA fillers are the fillers that break down a little faster and may not last as long, but I like to use that as a selling point because we don't know what we're going to look like or feel like in 5 or 7 or 10 years necessarily. It's good to have that control. I think that's why we haven't really seen a lot of companies come out with permanent products, because we like to have that control over the way that we look. But yeah, so over time, always is going to be better for their finances. It's going to be better for the downtime. But there are those people who are preparing for weddings, mothers of the bride and groom, who come in who need, that quick fix. And it's great to have tools in the toolbox to allow them to achieve those goals as well. But yes, high impact, HIIT people, the CrossFit folks, high intensity interval training, it burns a lot of calories, and I warn people about that as well. Don't lose too much weight after the age of 40. Make sure that you're in good cardiovascular health, but your goal really shouldn't be drastic weight loss, because you're going to come to me to replace it in your face.
And Shino, similarly, when you're talking to your patients about the cheeks and the temple, I think that you've been somebody who's used quite a bit of sculpture over the years in terms of, consistency from probably the past decade. You've been a big sculpture user for your patients. So how do you advise patients on when you're going to actually choose something like Sculptra in the cheek and the temple versus when you're going to go for an HA?
So for me, this is really easy because my practice is primarily driven with Sculptra. I do that all day long. And I believe that anybody that's 50 plus and they're not doing biocollagen stimulators and relying only on HA, doesn't matter who does the work, unless they go to a plastic surgeon and get it styled. Because remember, as a dermatologist, I'm preparing the patient for that day in the operating room. So I try to diminish the amount of HA that I use on patients that are 50 plus, because you started to get a very unusual look. If you need 20 syringes of HA to make that patient to lift them, it's better for them to go to a plastic surgeon. Basically, the aging process through the decades, I feel that aging is architectural changes, 25 to 35 architectural changes on the skin. Close to 40, you start looking tired. But when you get to age 50, then bone loss, bone remodeling is my concern. So let me show you this patient that I met at an event. This is a patient that I met at a New Year's party. Nobody was saying nice things about her. This is a face, basically the volume is adequate, but she had bone loss, bone remodeling. She's not fooling anybody. So what I did, I melted the HA, and this is 2 months post one session, full session of polylactic acid. You can see the look of an HA on a bone that has remodeled versus the look of polylactic acid over the periosteum, imitating the periosteum and the deep fat compartment. It looks more natural for 68 years old. 1 year later, the same party, this is her, what she looked like after polylactic acid. So for me, polylactic acid should be an option for anybody that's 50 plus, because you're relying only on HA. Eventually, they will look like an elderly person with fillers, and that's not the goal. The goal is trying to make the patient look the best version of themselves. So if they refuse to do polylactic acid, then I refer them to a plastic surgeon, because I certainly not going to have or make somebody look like they're a balloon full of hyaluronic acid only.
So Kay, living in LA and taking care of some of these patients who actually you may see out and about that don't look quite right, what Shino's talking about in terms of dissolving filler, how does that conversation actually go? If somebody is there, do you advise them? If somebody introduces them to you and says, hey, this is Dr. Durairaj and she's a facial plastic surgeon, how do you go about doing that? How do you charge people to dissolve things and start over again as well?
I think it's such an important part of our responsibility to speak to our aesthetic eye honestly, and patients really value our input and judgment. So I spend a long time doing a beauty plan on their face, and I'll just legitimately, honestly tell them when I feel like, I think that your under eyes, cheeks, lips look a little overfilled, and I would suggest that why don't we erase some of that away with some hyaluronidase. And I charge by the vial, just about $350 per vial, which is, a bit more than it costs us, but for the expertise and the time, I just want to make sure that they're invested in this process and they'll follow it up. And we'll dissolve, technically the half-life of Hylenex is short. It's only 2 minutes. 50% of its activity is over in 2 minutes. So technically you can refill the very next day or 2 days later, but I typically will wait 7 to 10 to 14 days just to let swelling go down, do some lymphatic massage and decompression. And uniformly, patients are so grateful when we dissolve overfilled under eyes or overfilled lips, their first reaction is, I feel normal again. They can tell that there's something wrong with their look and their appearance. And just as Shino said, there's something to be said for this abnormal turgor and water pressure from all that hyaluronic filler content in the face. Like, we can see gel is in their face and they may not be able to tell it, but we see it on our follow-up visits. And I think it's so critical to start building collagen stimulation for all these patients. But I think we're in a phase now as 10 years of repeat filler treatments every 6 months have gone by, and these ladies and gentlemen are so invested in maintaining their attractiveness. We've trained them, and I love that about our client base, that we all want to look our best and we put in the time and the effort. But now it's created this overfilled phenomenon. So all of us are going to have to become better at erasing the overfilled face. And, thankfully we have hyaluronidase. It's going to be a bigger problem for polylactic acid overfill or calcium hydroxyapatite overfill. And I think the biggest problem also is addressing not just spot treatment. When people come in and they want lips, they want cheeks. Well, they don't need a feature glued on. They need our assessment to say, well, this is where you have volume loss. Let's pull back your temples. Let's pull back your mid-face. Let's not put weight into lips that are already heavy in the lower third of the face. So I think we ourselves as aesthetic providers, we're 50% of the problem, that we are treating people, giving them what they want instead of holding back and teaching and educating, which takes longer.
I've been publishing on hyaluronidase since about 2006. And honestly, that conversation you can have with somebody in the office is something that's just rolls off your tongue. It's easy. We do it all the time. We want people to really represent our work. The conversation that Shino had at a cocktail party is very difficult. Michael, Corey, have you had things in those circumstances? I've been unable to really do sort of that transition where to really advise somebody on something other than like a skin cancer or something like that.
I think of it a couple ways. I just happened to me over the weekend. I was at a birthday party and a woman came up to me, and I never met her before, but she knew what I did. And she was like, do you mind talking a little shop with me? Does it bother you? And thankfully, before I could really answer, I was interrupted. But a lot of the times when women and even men come up to you and they ask, I mean, if they're asking, I think, well, I feel like I could give them a little bit of an honest response. I don't have to be the harshest critic that they're going to hear tonight at the cocktail party, but give them a little bit of guidance and then kind of throw them a bone and say, well, we could talk more when you come visit me in the office, and then have a more in-depth, honest conversation with them about really what their goals are, because that truly is not the arena to be discussing their aesthetic goals. It's nice to kind of talk a little, oh yeah, lips look great, blah, blah, blah. But beyond that, I don't let it go much further than that and start drawing on their face and telling them what they need so they run out the door crying.
I hear you. And I think, by the same token, Kay indicated that really we have an obligation to really educate people out there about what they can look good about and overall the natural look, and what something can do when it's subtle, when it's subliminal sort of differences, as Steve Diane has written about. So Corey, what about you?
Yeah, I always welcome the opportunity to educate people about this and to open the door to conversation. I think that when people are asking for your opinion, they still don't necessarily always want to hear the very harsh truth. So how you deliver it is important. And again, I like to get the story, and I like to try to figure out what it is that they have perceived as something that needs improvement before I just dive in, because that's another reason I think that people choose one doctor over the other, is the approach to the patient when they first walk in the room. And I hear time and time again about doctors in my area and wherever that just walk in and immediately start picking people apart. So that never feels good. It's not productive. It doesn't give anybody the sense that you are really there to help them. So yeah, just an open conversation. I think that they do want your opinion, but again, like Kay said, it's a great opportunity to educate them. Because I had a patient who told me once that she would never leave me because I never gave her exactly what she wanted. And she recognized that I knew better than she did what she needed. And that's the kind of relationship that I'm after with all my patients. I just had two patients that that I chose that I think really exemplify this, a few different things. Number one, we've all talked about the importance of treating the entire patient, having a long-term goal in mind, and really educating them about what they needed. This woman was in her 40s. She was going through a divorce. She was feeling and looking every bit of it. And she just knew that she didn't like what she saw when she looked in the mirror. So she's looking for a fresh start. And most people would probably go straight to the nasolabial folds, fill that and kind of keep it moving. But we really took a different approach and showed her what kind of improvement she would get by having a more holistic correction. So this is a story of a few different things. Number one, it's a story of not focusing on one area, focusing on the whole patient. It's another story. The other part of the story is how small amounts, 7 cc's is not that much product, but when you look at her, but it can sound like a lot to a patient from financial reasons and because they don't really understand what 7 cc's is, but how big of an impact that small amount of filler really can accomplish, and give a person a sense of self back and their confidence to go out and face the world. The majority of the filler here is actually in her temples and in her cheeks, which always surprises people when I tell them that, but it just gets back to the point that the foundation of the lift really starts at the top, and you have to have that foundation laid so that everything else can be successful. And we talked about this on other calls with Shino. The fact that we're seeing a lot of overfilled tear troughs is because people aren't looking at the face holistically and really treating the areas that really need the volume correction. So she was starting to look masculine. She was starting to have a square face. She was just looking tired, and just a touch of filler really brought her back.
She has the perfect amount of infraorbital augmentation there. You said you focused on the cheek, you focused on the temple. Some of the studies actually show that when you're specifically injecting those areas, you tend to reflate the infraorbital area. But how much volume do you actually put in the infraorbital hollow?
It only ended up being about 0.2 to 0.3 on each side. So not much at all. A little went a very long way for her. And the same in the nasolabial fold. We did add some there, but not nearly as much as you would think if you hadn't have laid that foundation from the top. So she got a really good lift, a very good profile improvement as well. We did just a touch in the chin, which you can see on that side view. And she was overall just very, very pleased and very happy with that. And we went very conservatively on the lips. She told me that I did not have permission to do a lot. So I think there's only like 0.4 in her lips, but just enough.
And the profiles her as well?
Yes. So just sharpen the angle of the jaw a little bit better. We added a touch in the pagonian of her chin to give her a more feminine appearance, and just to sort of balance out her nose and lips that we also gave some attention to there as well. And then this is another beautiful Native American woman who just needed to pick me up. She's gorgeous. But again, small amounts of filler placed well. She looks like she's lost about 20 pounds. This is only 2 weeks later. She hadn't. We gave her a more defined lower jawline and chin area, which just sort of completes the look and helps her to not look so top heavy and full in the face. But this is a classic example, again, of a patient who can have filler and actually end up looking slimmer. My favorite, the 45-degree angle for Kate is even more impressive. And I mean, that lift and angle and just light reflex and even the gleam in her eye, I think, looks a little bit better with just a touch of filler in her cheeks.
Did you put something above her brow? It looks like she has quite a bit of a brow lift itself.
So that's all temple. There's nothing in the brow itself. We did do some toxin on that first day as well. So that might be a bit of a brow lift that you're seeing reflected there with the neurotoxin. Just completed the story. We wanted to honor her features that she's so proud of with her Native American culture. We are never into making somebody look like somebody else or morphing them into a different culture or caricature of themselves. So always trying to honor that and keep the patients true to their own essence.
Great stuff. They both look really natural and fantastic.
So I actually want to go over a few examples. It's actually some of the concepts that we've discussed. So it's great because it kind of reinforces some of the anatomy and some of the gender differences. So on this one, this is an example of one of my male patients who comes in to improve and enhance the appearance of his jawline. And to the point earlier that I had spoken about, I always will start them off on a hyaluronic acid filler. But he had been a patient of mine for the past 18 to 24 months and had done a few syringes here or there, kind of dabbled in it, and eventually decided he wanted something a little longer lasting, short of surgery. So I offered him Bellafill, and this is after a total of 3 syringes, which actually ends up only being 2.4 cc's in the Bellafill world because they're 0.8 cc syringes. And so I did as with all my jawline patients, I did a cannula technique and really filled in the angle of his mandible as well as the chin and mentalis region. And some of the things that I'm always acutely aware of with male patients is the angle of the gonial angle. And it is more acute in the male patients. And so it is okay to give a little bit more definition and angulation to that area because it is considered a very masculinizing feature. And I also gave him a little bit more chin projection here. So it kind of just gives him a very smooth contour. It conceals any irregularities and defines that angle, which again is considered a very masculine appearance. On the next slide, this is an example of a female patient. So a little bit of a different approach. I use 3 cc's of an HA filler, Restylane-L specifically, which is one of my favorite fillers for the jawline. But you can see sort of the differences here that I focus on, and it's to create a little bit more obtuse and even a softer gonial angle. So you don't see that sharp 90 or 95 degree angulation at the angle of their mandible, and rather it's a little bit more rounded, a little bit more softer, and something that I consider more feminine. But it doesn't mean you can't augment and rejuvenate and enhance the female jawline without making them look non-feminine. And I didn't put much in her chin because again, I want to stay a little bit deprojected for the female chin, a little bit behind that lower lip to create that overall softer appearance. So they're both augmented in their own right, but very differently with the approach and the amount of volume that's needed to get the result that we want. On the next slide, so this is actually talking about lips. This is a classic example of a mid-50s-year-old patient, some upper lip asymmetries. They're starting to get an elongated upper cutaneous lip. And this, to someone that just glances at it, may look like something, pretty straightforward, but this is something that I consider quite challenging when you see an asymmetry of this sort, because it's not just lack of volume to the left upper lip, it's actually an asymmetry to the cutaneous part of the lip itself. So short of doing something surgical, you really have to work at this. And on the next slide, I show exactly the volumes that I've used in a very asymmetric fashion. I used only 1 cc of Restylane, and I had to put almost half a cc on the left upper lip in order to get that body to pop up. But I was able to do it, and I kind of surprised myself actually, because I didn't think that I'd be able to get this level of symmetry. And in retrospect, I would have liked to have put a small amount more in her lower lip to soften some of those lines, but overall, she got a lot better symmetry and she was very happy with that. And so those were the goals for this lip. In contrast to the next slide, which is a very young patient, this is someone of Asian ethnicity in their early 20s. So she has great shape to her lips. And I think most would look at her lips and say, well, what are you going to do to her lips? She doesn't need anything. Great Cupid's bow, great body. And going back to her ethnicity, she's basically a 1-to-1. Never had filler in her lip, and her proportions are 1-to-1. So I really wanted to maintain that. So my goals for this type of patient are really hydration rather than volumization or augmentation. And on the next slide is a very low G' filler. I think I used Restylane Silk on this patient. And I just basically added subtle amounts of hydration in the submucosal borders or submucosal planes of both the upper and lower lip, and even gave just a touch in her philtral columns without really doing anything to the actual vermilion border. And so my goal really for her was hydration. I think the end result looks much more hydrated, and I maintained that ethnic proportion that she had, which was 1-to-1.
I think this approach to the filtral columns makes a lot of sense. For somebody who has a filtral column at baseline, you're really taking the peak of the Cupid's bow, you're angling in a little bit, probably about 15 degrees. If you go back 2 slides, you know, that patient never really had a filtral column, and you correctly, in my opinion, didn't really approach it because it's not something that they would look natural having. And when Shino presented that patient that he saw at the New Year's party, one of the things that looked funny was not just the proportion of the lip, was the artificial appearance of the filtral columns. And I think most of our patients don't realize that there's so many different things you can do with the lips. So I'm a big resurfacing person. I look at this patient and I say, you've restored the volume beautifully, Michael. And I think the patient at this point could think about some resurfacing because there's too many lines and wrinkles, and I would use full field heavy erbium. You know, you might look at this patient and say, well, you know, the distance between, you know, the area of the columella and the lip itself is long. I've seen you do this surgery before in video at different conferences we've both been at in terms of the lip shortening procedure. Let's talk about some of the different options that we have as physicians that do injectables or as physicians that do surgery, or both, that we can really help patients look better even when they don't know all the options. I don't think putting Cupid's bows or, you know, a prominent columella on, but important, or filtral columns are important on everybody, and how you really approach that.
Well, I think that, yes, we have a lot of items in our toolbox. And short of, you're right, doing a lip lift or something surgical on her, I think periorbital and perioral, basically facial rejuvenation using I know your favorite's erbium, and I use a lot of CO2 in my practice. And I really think a lot of that complements what we do to the patient. And to everyone's point that we've all touched on, it's about looking at the patient globally. And I know I've zoomed in to 1/10 of the patient's face on this photo, but you know, the more global perspective is targeting cheeks, jawline, volumization in general, collagen stimulators, our resurfacing. And again, I think that every year, every month, the technology is improving, and for the better. And I feel so grateful for that, because we all contribute to our own respective fields. And you know, there's just so much out there that we have at our disposal to help our patients along in their aesthetic journey.
So just looking at these slides, I think we already talked about the beauty of lip augmentation, and just the lady on the left side being here an example of younger lips that already are robust and have a good shape, but just like Michael's slide, adding a little bit more volume and taking away the linear creases just looks hydrated and pretty. The lady on the right side being a little bit older, and my technique for older lips tends to be reestablishing the lip border. I almost always will put some philtrum border, and I'm a big fan of treating the oral commissures, which I feel lose competency in all of us as we age. So I think the other aspect of lip treatment is pulling weight off of the upper lip by giving mid-face support. So I put some cheek filler here. This is 1 syringe of calcium hydroxyapatite to elevate the cheeks, and also Botox treatment. I rarely will fill the nasolabial folds. However, I do recommend filler in the piriform aperture just to lift weight off of the upper lip. And someone may be a candidate for a lip lift surgery, so I'll talk seriously with them. This patient here in this picture was a candidate for lip lift, given that she had more than a 13 millimeter distance from the philtrum to the Cupid's bow. However, Building the upper lip volume, adding filtral support, and adding some piriform aperture filler can also give you several millimeters of improvement. So I think that looks nice. So on the next slide here, on the left side, treatment of the under eyes in a younger person versus an older person. So in this younger person, she has very heavy cheeks, and the cheek, I think, is central to treatment of the eyes. The weight of the apple of the cheek pulling down creates so much gravitational pull and flattens the mid-face, mid-cheek area. And here, just placing some lateral cheek filler with calcium hydroxyapatite improved her under eyes tremendously, gave her a slimmed appearance of the face, and I think took the weight off the eyes without doing any under eye filler. And I remember thinking this was a success for this lady. She had a 1 syringe budget, her eyes bothered her, but we slimmed her and her eyes looked better. And she wrote me a bad Yelp review because she said she went home and still didn't feel like she had enough treatment of her under eye hollow. But for me, I thought that was a win. But I think that also makes me always think about the patient perspective, because here I thought I was improving her outlook and she really just wanted to treat that dark circle. Conversely, in an older patient on the right side, a similar approach where I think if you fail to treat the lateral or outside orbit, you're not going to be able to improve the under eye area successfully. So she's someone who I would have taken the surgery. I'd say most likely you're not an ideal candidate for tear trough filler. I wouldn't recommend it. But more and more, I'm pushing the envelope and doing under eye filler, starting with the conversation that the gold standard for you is surgery, and I don't recommend under eye filler. And if you tell me you're never in 1,000 years going to consider surgery, then we'll talk about filler. So then we're ending up with these borderline cases where I normally wouldn't do filler, but the results are turning out quite well. And I think using, a mid-face support, using a triangular cone of filler just at the orbital rim, treating that deep medial cheek fat area is very important to support the globe and allow the prolapsing orbital fat to fall inwards. So I use that technique of building lateral cheekbone and then placing some filler in the mid-face just as a support structure. And that's a nice example for treatment of under eyes. And then here, cheeks for younger and older patients, both successful examples of tapering and contouring the face and lifting the weight. And I tend to tell my patients that 70% of their beauty is their cheeks. And I think in making their beauty plans, almost uniformly, step 1 in everyone's beauty plan would be mid-face filler with cheek augmentation to lift weight off of the jowls and to give support to the under eye structure. That one injection treats so much. And that, with a little bit of Botox, is a really nice introduction to anti-aging for people who haven't done anything. They see the difference and they can improve. They feel the improvement. They feel prettier. So I think both the young and the older woman will benefit. For older patients, I am recommending a full syringe on each cheek. And typically, I think they need to, generally a syringe per decade of how old they are is reasonable if they've never done anything. And it's interesting because as a surgeon, this is a facelift patient. Our older lady on the right needs a facelift and a neck lift, but we are just, treating more and more patients with this approach of volumization. But I also think that we need to rein that in as we get too much filler placed in too many locations, and we need to go back a little bit into surgical facelift. So I tend to start a lot of conversations with your candidate for facelift and neck lift, and then they give me a horrified look, and then we go back to talking about filler. But and jawline filler we spoke about earlier, but this is an example of how treatment at the angle of the mandible kind of improves lower face jowling centrally. So in both of these patients, they had half a syringe of filler on each jawline for the young person and a full syringe on the older patient. And the angle of the mandible is able to give significant pull, lift, and support to where they do feel less jowling. I think to get fully around the jawline, we need 1 full syringe per jawline for young people, and for women in particular. For men, I tend to do 2 per side, and for older faces, I think 3 is a good interim. Those are my thoughts